Hi everyone, welcome to lesson 13 of the Health and Wellness for Older Adults course. We're finally progressing. We're coming close to the end. We have a few more left. So this lecture or this lesson is going to be about just straight up medical care in older adults. Okay, so let's go ahead and get started. Okay, so what sources of income do older adults have? First of all, there is Social Security, and I think we all kind of understand this, right? This started in 1935. It's financed by working adults through our taxes, right? The income taxes that we pay. And then as you go throughout your life, working and whatnot, you earn credits in your working career. Okay, and then in 2005, the average Social Security income for a man was almost $350 more or over the poverty level, and even less than that was less than that for a woman. So Social Security doesn't provide that much. Okay, it's not that great. It's just it does help as a supplemental source of income, but it's difficult to live off of Social Security alone. Next, there is supplemental security income. So this was established in 1974. Okay, and this is federal income that's a federal income supplement program that's funded by general tax revenues, of course, not Social Security taxes though. That's separate. Okay, so that's something that we need to recognize. It's separate from Social Security. They're not the same thing. All right, this one was established in 1974. It is funded by taxes, just not Social Security taxes. And it's designed out there to help people who are old, blind, disabled, and whatnot, who have little to no income. Okay, and this will provide cash and whatnot to help meet needs for food, shelter, clothing, things like that. Okay. So other sources of income that older adults have would be personal assets. So if they've had a savings throughout their life, if they have home equity, sometimes you can do like a reverse mortgage on that. So we won't get into how that works, but it kind of, in a way, it's like the bank is buying your house back from you, kind of. Anyway. You might also have, or so, people might also have pensions from when they worked. Okay, so they might have pension coming in from their employers from all those working years. Also an IRA, so an individual retirement account that they may have set up on their own, in their younger years, and they could have just been, putting money into that. So that would be money that's set aside from paychecks and things like that. Usually you put that into like stocks or bonds or something, and then you're allowed to use it as retirement, or sometimes with your IRA, actually all times, you can actually borrow from it as well. So you can borrow from it, and then it's like you can act as your own bank in a way. You can borrow from it, then you pay yourself back in interest, and you get it? It's like that. Instead of paying the bank in interest, you're paying yourself. Okay, and you can do that during your younger years, and then when you're retired, you have access to your IRA. Okay, and then of course some older adults still continue to work, especially if they're healthy enough. They may continue to seek out employment. So now let's look at the use of medical services in older adults. So I think a lot of this was expected, but older adults do tend to use medical services more than younger adults. Okay, so they average about 7 doctor visits per year, which is twice that of younger adults. Okay, their hospital admission rate is 3 times that of younger adults. Older adults are twice as likely to be prescribed their medication from a primary care practitioner, and then older adults spend 3 times more money from their own pockets than people who are younger than age 65. Okay, which is probably something we already would have assumed. So how is their medical care even paid for? Okay, so most of the medical care for older adults are going to be paid for by Medicare. Okay, remember Medicare, you're eligible to receive Medicare benefits once you hit 65 and older. So Medicare actually handles a lot of, is paying for almost all of their medical care. That being said, Medicare is not free. So you're going to have a lot of out-of-pocket costs and whatnot, and also there may be some services that are not going to be covered. Okay, so Medicare is pretty good for the most part. It's just for too many older adults, it gets difficult because it's not free. There are out-of-pocket costs that they have to pay and whatnot, and it really hurts them financially. Okay. That being said, for those older adults who qualify income-wise, they may also receive Medicaid. And Medicaid will cover Medicaid. Well, it depends on if you're partially covered by Medicaid or if you're fully covered by Medicaid, because you can also be a dual. If you get Medicaid, you can be a dual beneficiary, but you may not be a full dual beneficiary. Okay, so it just depends on what you qualify for. But if you partially qualify for Medicaid, or for to receive partial Medicaid benefits with Medicare, what that means is that basically Medicaid is going to cover your out-of-pocket costs. Okay, now if you have full coverage with Medicaid and of course with Medicare, that means Medicaid is going to cover your out-of-pocket costs, but anything that Medicare is not going to take care of, Medicaid will take care of. Okay, so it helps quite a bit. But also there's the VA as well. So U.S. Department of Veteran Affairs. This is going to be completely funded by the federal government. Okay, and this is of course for the veterans. And so this is a good old public health insurance, but it's only for the veterans. Okay. And then there is the Indian Health Service. This is also federally funded, but it's only for those who belong to the native tribes. Okay. And then there are, of course, private health insurances out there. And, many people still are able to hold on to their private insurance even after retirement, because that was like in their severance package, or that's what they were, promised if they work a certain amount of years, or if they retire with a certain company, they were supposed to have keep their private insurance, and that's supposed to be paid for them. So some older adults also have their private insurance. Okay. Okay, Medicare. Medicare is divided into 4 parts. Okay, so Part A, that is the hospital insurance. Part A is the part that covers all your inpatient stuff. Okay, this is also going to not only cover the medical side of your inpatient stuff, but this is also going to cover the psychiatric side as well. And also long-stay hospitals and all of that. Okay, Medicare Part A is supported by your payroll tax. Okay, so, and then Part B, this is the medical insurance part. So Part B is going to cover your outpatient stuff. Okay, visiting the doctor, getting imaging done, maybe getting like a specialist consultation, things like that. So it's usually going to cover more primary care, secondary care, and that kind of thing. Assistance through Medicaid may pay the premium for low-income older adults. Okay, so this is where a lot of the Medicaid, if you're a dual beneficiary, would kick in and pay your out-of-pocket costs for you here. Now, then there's Medicare Part C. So this is if you choose to, it's not required, you don't have to do this, but if you wish, you can receive your Medicare benefits as or through a managed care plan. Okay. And usually the managed care plan, it sort of just really depends on which managed care organization is in your area. Okay, and if they accept Medicare, because if they do, then you can sign up with them and receive all your managed care benefits through them. And a lot of people hate this, but there are a lot of people who really like managed care because of the structure. Okay, so a lot of people will definitely be like, yeah, Medicare Part C, I'm definitely into it. Anyway. And then Medicare Part D, this is the prescription drug coverage. And again, this one is also optional. You don't have to do this. Okay. If you wish to pay your Medicare drug or your prescription drugs all on your own, that's cool. But I doubt anyone's going to opt for paying them by themselves. Okay. Okay, so the original Medicare plan. So Medicare is actually it's the same all over the country. All right, it's not going to change from state to state. It's a federally funded program and it's federally controlled or operated really. So your benefits, or it should be standardized throughout the entire country. Your benefits in California would be the same as they are in Minnesota. Okay, it doesn't matter where you go in what state. That being said, if you opt to choose for Medicare Advantage, Medicare Part C, and you're receiving your benefits as a managed care plan, then the managed care plan that you're using in California, it could differ in Minnesota if you find a managed care plan that you want to use in Minnesota. But the benefits itself, Medicare itself, is not going to change. It's just how you receive them if you choose to opt for Plan C or Part C. So anyway, so the government, okay, so older adults can go to really any doctor, any hospital, any pharmacy as many times as they need. That is true if they accept Medicare. Okay, so any physician, hospital, pharmacy, anything like that, they have to actually be certified in order to even accept Medicare. And then that way they, can accept Medicare patients. And that way they can get paid from Medicare. And many organizations will definitely opt to be certified to accept Medicare because, a lot of people in this country have Medicare. But then there are definitely those facilities who decide that they don't want any part of that. But anyway, so what they say that may happen, since you can technically really go to almost anywhere to receive care, this could lead to uncoordinated treatment. And that's very true. I mean, that's what we're seeing a lot of, especially a lot of misuse and whatnot in older adults in Medicare, in medicine, because since older adults can go to one hospital or one physician and they know that, as long as they're certified to accept Medicare, then that physician is going to take care of them. It may not be their usual physician. It may not be a physician that is within a certain network. That older adult might not care about Part C at all. And so they're just kind of going wherever. Well, when that happens, is the care that the physicians that they're receiving care from, they might not be communicating. Okay, they might not be sharing information as easily. Okay, so there might not be very good coordination of care. And if that patient doesn't even remember exactly what work was done to them, they don't know every single medication that they're prescribed and anything like that, then the physician that they go to next will just be treating them as if they were kind of new, and they might not have all the history that or all the information that they need to properly care for that patient. Okay, so there could be a lot of overlap in medications and a lot of care, and there could be like a lot of drug on drug interactions. Okay, when this happens, and it's not necessarily the physician's fault. It's just they weren't given that information and they didn't know where this patient was seen last. Okay, so it could lead to uncontrolled treatment. Okay, that's why it is good to have it. That is one reason why receiving your Medicare benefits might be really good to get that through Medicare Part C, through a managed care organization. Anyway, so managed care plans. Managed care plans can be either HMOs or PPOs. Truth is that they're a bit more complicated than that, and there are many other different types of managed care plans, but the most common ones that we're going to deal with out there, the most common ones that are out there, the ones that are most familiar even to people who are not in medicine, would be the HMOs and PPOs. Okay. So anyway, that's something you guys need to know. All right, so in most, at least every HMO situation, not so much PPO because they do give a lot of freedom in with PPO plans, but every HMO, they're very strict and they make it so that your primary care physician is your single point of contact, and that's like the one way that you can get into the healthcare delivery system. Okay, so that primary care physician is managing all of your care. They know your history, and they know each physician or specialist that you're going to because they're the ones that sent you there. Okay, so since they're part of the same network and they're the ones that sent you there, they're definitely going to be able to have access to any kind of information that those specialists are, about whatever those specialists are doing for you. So they're going to be able to keep track of what's going on with you and handle your diseases or whatever you have a lot better. And there's going to be less overlap and it's a bit more coordinated. Unfortunately, a lot of people don't really like the fact that they do give you less choice of doctors. It isn't really standardized throughout the entire country, so every managed care organization is going to have its own standards, its own network, its own, whatever that's separated from all the other, plans, all the other networks. Okay, so it's almost like its own healthcare delivery world. Okay, once you're part of a managed care organization, once you have a managed care plan, you're part of that like little network world of healthcare. Okay, but if you go outside of it, then you're kind of on your own. It's not going to be the same. It's not standard like what you're used to in your own little, managed care world. So it works great. Managed care works great when you are in it. Okay, but if you try to go outside of your network, or you start out with a new organization, a new plan somewhere else, then it's going to it always takes some adjustments, an adjustment period, and it might be difficult for older adults to get used to that type of a structure when a lot of the older adults who are going into retirement now, back in the old days, they didn't really have so many restrictions with their plans, and it was common actually that a lot of these people, I think this is the generation that has always hated managed care. Okay, they like the older days when you can kind of just go anywhere and your insurance would just cover that. So anyway, so managed care plans, there are increased benefits and definitely going to be lower out-of-pocket costs, especially if you have an HMO. Okay, HMOs have lower out-of-pocket costs. PPOs tend to have more out-of-pocket costs, but the reason for that is because they give you a lot more freedom. Okay, PPOs tend to not force you to go straight to your primary care physician before you go see a specialist. Okay, they encourage it, but it's not a rule. Okay, they don't force you. They don't say, well, if you don't, then you're going to pay out of your own pocket completely. They don't, they don't say things like that. Okay, so bad news about managed care plans. Actually, this bad news that, well, back in the old days, okay, before the Affordable Care Act happened, a lot of these plans, okay, they really only wanted to enroll people that were a lot healthier, because those people were less risk. They're going to cost less, okay? And if they were, because many other private health insurances out there tend to, when they evaluate your level of risk, they're going to charge you extremely high premiums. And while many HMOs or PPOs don't tend to do that, they don't look at your level of risk and charge you more for being high risk. They usually just don't even want to deal with you if you're not very healthy. If you're going to be using the insurance money a lot. Okay, so Medicare benefits. Some of the cool things about Medicare is it's universal availability everywhere. You get that free choice of providers, provided that you do not opt for the Part C, because if you do, then you're going to get through a managed care organization and they're going to have rules. So there's no need for permission if you're just using straight Medicare. Okay, no need for permission to go see a specialist. You can just go straight to see a specialist if that's what you want to do. There are limitations though. So it does not reimburse every service. Not every service is going to be paid for. Okay, that's why it's good. In addition to Medicare, it's good to have Medicaid or have another type of insurance. Okay, your private health insurance that you kept from your work that you retired with, that's a good thing. Okay, so it can get too complex. Many doctors have less money and have to make up for it. So Medicare does not pay physicians very well at all. They pay pennies on the dollar. So the physicians that choose to certify and take Medicare, they have to try to figure out how to compensate for those costs that they lost for taking care of their Medicare patients. So they always have to try to find some way to make up for that. And sometimes that will lead to fraud and abuse with Medicare. Sometimes some physicians or some practices might go, well, you know what? We're going to bill Medicare for something that wasn't even done. Okay? And so they try to, find ways around the system and try to get as much money as they possibly can, even if it's illegal. Okay, even if they're kind of tricking the Medicare system and billing for things that weren't even done or whatever. Okay. So anyway, moving forward, Medicaid. In California, it's called Medi-Cal. Okay, every state is going to have their own. I think in Oregon, they call it the Oregon Health Plan. Okay, but every state has their own Medicaid plan, and they're going to call it something different. Okay, so Medicaid supports those who are low income, blind, disabled, any age. Okay, eligibility is based on your monthly income and your total assets, and it's going to be different for every single state. It's actually different. Everything is going to be different about the Medicaid program going from state to state. Okay, the amount of money that's available for the Medicaid program, the eligibility that's that the eligibility requirements for that Medicaid program, and also the services that the Medicaid program is going to provide for the beneficiaries. Okay, that's all going to be different from state to state because Medicaid is provided for by the states. Okay, the federal government pushed the Medicaid programs over to the states and let them deal with it. So you might find that richer states might have more money for their Medicaid program. They might cover more services. They might their eligibility requirements might be a bit more, or might be allowing a lot more people to qualify. Like maybe they don't require you to be as poor, as other states would require you because there's more money to go around. So, and then in states that don't have as much money, their Medicaid program might be a bit more restrictive, and the eligibility requirement might be like even lower. Like you might have to be really, really poor to even qualify to receive Medicaid from those states. Okay. Okay, so the VA. Okay, all veterans over 65 qualify for VA services. VA facilities play a role in medical education and research. Okay, and the VA offers physician services, hospitalization, home health, and long-term care. And so it provides all of that. And it's only those specific people who are veterans may reap those benefits. This is going to be funded by the federal government and operated by the federal government, not the states. Okay, and then so there is a bit more money into it. Okay, so Indian Health Service. This is an agency of within the Department of Health and Human Services. Okay, so this is going to be a federally funded program. Okay, so Native American older adults comprise less than 6% of the service population in this situation, but this does not only service, or this does not only provide health services to the older Native American adults, but it provides it to the whole population, for the whole Native American population. Okay, so there are not enough resources out there to help with long-term care or rehabilitation, unfortunately. So it's mostly just your typical, just regular health services, hospitalization, medical services, things like that. But typically when you get into long-term care rehabilitation, it's unfortunate that they're not paying for that kind of thing. So out-of-pocket expenses. In 2006, older adults spent an average of $4,200, or 16% of their average household income, on out-of-pocket expenses for their health care. Okay, healthcare costs have increased faster than inflation. Okay, that's pretty insane. And a lot of this is largely due to all the new medical technology that we do come up with, because every time we do come up with new medical technology, it's all going to be a lot more expensive. So that's what happens. The high cost of care. The United States faces increasing numbers of elders each year. Okay, so older adults are high users of medical services. We already knew that. Profits from prescription drugs are extremely high, and we kind of already knew that too. We already went over the prescription drugs are ridiculously expensive. They're extremely high, and the people who get paid the most for the prescription drugs are those who work in the middle. Okay, all the middle people profit a lot from that. So anyway, fraud and waste really drives up the costs, and there is quite a bit of waste in what this is. And like I said a couple slides ago, a reason for a lot of the fraud is that Medicare doesn't pay very well for their services, for medical services. So many physicians out there, they try to figure out ways to balance the costs, okay? Especially if a lot of their patients are Medicare patients, okay? So if they're not getting a lot of other patients that, so if Medicare's not, they're not getting enough patients that pay a lot more, then they're going to find ways that they need to find, other ways that they can take out more money from the government. And then there is a lot of waste as well, because there's a lot of overuse of medical services and whatnot. And a lot of this also goes back to the fact that Medicare does not pay very well. So many physicians, facilities, organizations, and whatnot, they're really trying to go out there and with their patients, they want to prescribe as many or order as many tests as possible so that they can get the money on that and things like that. And a lot of the tests or maybe treatments and whatnot are not very necessary, and they know that, but they're still going to order them because they need the money. Okay, of course, the patient is exploited in this situation, and since it was completely unnecessary, we're just wasting resources. Okay, so anyway, now let's look at for-profit medical care. Okay, so studies indicate that for-profit hospitals are costlier and less efficient. Okay, and they may not have important services like an ER or trauma care. These services are important, but they're not really profitable when they have them. So there are higher death rates and higher payments for care. So inequities in treatment. Okay, so let's look at race and ethnicity first. There's a huge difference in care between blacks and whites, rather. They use whether or not they use Medicare or private insurance, or they're paying out of pocket, or they have Medicaid or anything like that. There's a major difference in care. Okay, so a huge goal in every time we do have the Healthy People new initiatives for the next decade, a huge goal that's always included is to find ways that we can reduce a lot of these inequities and help those disparities. Okay, and then also with gender as well, women have higher rates of chronic illnesses and disabilities, but they're less likely to receive some services. Okay, so poor outcomes are due to more advanced age, and usually when you get older, I think that's going to be expected. As we get older, we're less likely to have a positive outcome in our medical services. Okay, it's just because we're getting older. There's a lot more wear on our bodies and things like that. So inequities in treatment with age. All right, so healthcare professionals lack geriatric training, and that's definitely true. Older adults are less likely to get preventative care. Older adults are less likely to be screened or diagnosed with life-threatening diseases. Older adults are more likely to receive inappropriate or incomplete treatment, and older adults are also underrepresented in clinical trials. Okay, so that's a huge problem in treatment. If they're not represented much in clinical trials, then how do we know how we're supposed to take care of them? There may be different standards that we need to use when caring for older adults. Okay, so healthcare professionals definitely need more training. We need to also have more evidence-based practices involved in treatments for older adults. Okay, Then inaccessible services. So going to the doctor for many older adults might be really difficult, okay? Because many older adults need assistance, okay? They might not have transportation. They might not know how to obtain transportation, okay? Maybe they don't know exactly where to go, how, you know, to get a hold of their physician, how to go to the physician, things like that. And then Medicare raised the reimbursement rate for house calls, which is great because many home health companies do not make much money at all, especially through Medicare. Medicare pays less than pennies for home health. And it's really difficult, and it's actually pretty risky for the healthcare worker to go into people's homes. Okay, so Medicare should raise the reimbursement rate for all these home health companies. So anyway, medical house call program is a model for serving homebound older adults, which is a good thing because it does help increase access to medical services for many older adults. Okay, so challenges: lack of training in geriatrics. So by 2030, older adults will comprise half of the patient load of many doctors. Okay, because at that point, pretty much all of the baby boomers will be retired. Okay, so should there actually be a geriatric specialist, or should all physicians just be trained in geriatrics? If there's going to be that many, this is something for you guys to think about, but I believe that if there are going to be that many older adults who are past retirement, who are over the age of 65, it puts I think most physicians should just be trained in geriatrics. Otherwise, it's going to be an extremely high load or patient load on certain physicians, okay? And then other physicians won't have as much of a load to take care of, okay? Because you also have to take in consideration that older adults use medical services a whole lot more than other age groups, okay? So most physicians have more older adult patients than any other age group. So if that's the case, then yeah, it's just I believe that it would be a whole lot easier, a whole lot more efficient if these physicians were trained in geriatrics. Okay, so Medicare helps with the finance, helps finance physicians education though, through the graduate medical education program. So, all right. So the the lack of standardization of medical practice. Physicians treat patients based on education, experience, and intuition, right? So practice-based medicine is more popular than evidence-based medicine, okay? Because a lot of the practice-based medicine is going to be based on their own experience. And so given that, experience and intuition, that fits in way more to practice-based medicine than evidence-based medicine. That's more of like having to keep up with the latest advances and everything going on, and many physicians choose, and it does have a lot to do with our culture, but many physicians choose or prefer to practice medicine their own way. That being said, there are plenty of standards out there, and especially if a physician is working with a managed care organization, that's not really allowed. Okay. Okay, so the new shift. Okay, so we are kind of going through a reform in medical care and health services delivery and whatnot. So as we go through the new shift, physicians should be focusing on whole person care, okay? Looking at the person as a whole, not necessarily as just let's fix those physical symptoms, okay? And not just only the physician making the decisions and everything like that, but the physician needs to work as a team with all the other healthcare providers that are helping the patient, as well as the patient. Okay, so the patient needs to be part of that team as well. Okay, so this doctor-patient collaboration, right, working as a team. What's key here in this team, especially with older adults, is communication. So some steps that can be used in this practice, or best communication practices, can be to first slow down. Okay. Secondly, the patient should, or the physician, the patient, both of them, you need to include a family member into this whole situation. There needs to be someone else who has the patient's back and who the physician can also consult with as well, because sometimes the patient may not understand what's best for them. Sometimes the patient may not clearly understand what is going on with the whole, in their treatment and all of that. So it is best to have a family member involved in some way. Number 3 is to interpret that doctor speak. Okay, so the physician should be a little bit more clear, maybe not necessarily too much doctor speak, and that family member hopefully can be able to interpret a lot of the doctor speak for the patient when it's needed. Okay. So low health literacy. This is the ability, or health literacy itself is the ability to seek out, process, and understand basic information and services that are needed to make good decisions. Okay, so half of the Americans have low health literacy, leading to poor compliance in their health treatments. So what's most common in those who do not speak English? Well, and then those with low literacy use the healthcare system more often. So some solutions to this problem would be to use interpreters, okay, especially for those who don't speak English very well. It's pretty important to have interpreters there, or at least have a family member who can communicate on both ends, okay, with the physician and with the patient. Go to the doctor with a friend, okay, or a family member, right? Health professionals, they need to watch their use of language and to assure understanding. So they do need to not necessarily use too much doctor speak, and they need to just be kind of calm and really try to connect with the patient and use language that, use very simple, clear language that the patient would understand more. Okay, so the need for comprehensive care. When an older adult sees many specialists, this may cause an overlap or unnecessary services. Okay, I know we've talked about this before. There can be an overlap. There can be a lot of drug-on-drug interaction, a lot of other misuse, accidents, things that did not have to happen, but just because they weren't as coordinated, since that patient is seeing so many specialists, and the specialists are not communicating with each other, they're not communicating well with the primary care physician, things get lost, and that patient suffers. Okay, so medical services and community services are often not coordinated, and older adults may have trouble navigating the system. And this is why, in my personal opinion, why it is actually really necessary for older adults to opt in for that the Medicare Part C. Okay, use Medicare Advantage, because that is a lot more structured than than just straight Medicare, where you can kind of just move around and do whatever you need to do whatever you want to do, because that's when things can get lost. Using a managed care organization, although they may be strict and you may not like it, there's structure, okay, and there's a lot of communication. All right, so anyway, so some solutions: managed care may help. Also, using a primary care provider or a case manager can also coordinate your services, and that is part of what managed care offers patients. Okay. Also, use the interdisciplinary team approach where everyone works on the health of the patient as a team, including the physician, the nurses, the specialist, the patient, and the patient's family. They're all a team, okay? So anyways, next, cybermedicine. Cybermedicine is patients communicating with physicians through email, okay? This can be really convenient, cheap, private, anonymous, whatever. But without a physical exam or lab test or verification of credentials, patients should also be, careful. Okay, telemedicine itself refers to connecting with physicians through the telephone, fax, audio, video links. Just really, telemedicine is receiving care from your practitioner at a distance and remotely. Okay, and this can do wonders for those who especially don't have really great access to healthcare. Also for those who would rather save money. Okay, if you have to pay for most of this yourself, telemedicine is usually less expensive, although right now, currently, they're just sort of working out the kinks of reimbursement. So it is kind of difficult for them for many organizations to have telemedicine programs or telemedicine services because they don't know how to charge. Okay, so how does it get reimbursed? Will the insurance cover it? Will Medicare cover it? Okay, so alternative medicine. Most physicians in the United States practice allopathic medicine, okay, especially the MDs. If they have an MD degree, they were trained in allopathic medicine. If they have a DO, they were trained in allopathic and alternative, so they can do both. But most physicians in the United States will practice allopathic medicine because that is what's most common, that's what's accepted in the medical community. So allopathic medicine is what everyone does. That being said, it does not mean that alternative medicine is bad or it's less effective or anything like that. So alternative medicine can be used complementary. Many older adults have used some sort of complementary medicine, including supplements, herbal stuff, remedies, things like that. And it is important to share this information. When you do use a lot of alternative medicine, you should actually share this information with your physician because, if anything should happen or if maybe they know something that the patient doesn't and there could be some sort of interaction with their drugs, the physician needs to know so that they can advise the patient a little bit better. So anyway, that is the end of lesson 13. Hope you learned a lot. And if you have any kind of questions or anything like that, please let me know in the comments or email me, and I'll see you guys in the next lesson.